Hello, this is Don Withers, and this video is about the cardiac myocytes or muscle cells, how they receive a stimulus to cause them to undergo electrical changes, and eventually contraction. So a brief review. In my previous video, I talked about the electrical events that occur in the pacemaker and other similar cells that generate the impulse to spread throughout the heart and cause the muscle cells to undergo contraction eventually. These main stimulus for these electrical events occurs in the pacemaker or the SA node, and they're conducted through the wall of the heart to the myocytes through gap junctions. The myocytes in turn undergo electrical changes called action potentials, and these action potentials lead to the contraction, the mechanical event. In discussing these events in the muscle fibers, which I would like to focus on this video, we'll talk about stepwise changes that happen in the muscle fibers that involve changes to the membrane potential or the charge separation across the membrane of these muscle fibers. Changes in charge occur by movement of ions across the membrane. And so we'll talk about ion channels for sodium and calcium. When these ion channels open, these ions move across the membrane into the cell. So there's influx or inflow of these membranes into the cell. Another important ion is potassium. And when potassium ion channels open, it moves in the opposite direction, out of the cell. And so these will be important when we discuss the electrical events that happen in myocytes, and then how these are tied to the contraction that results. So the main topics that I'd like to discuss in this video are the electrical events that are happening in the cardiac myocytes, and then a feature of cardiac myocytes, which is a refractory period, relatively long in these cells. So we'll discuss what that is and the importance of a long refractory period. And then we'll talk about how the electrical events that are happening in all cardiac muscle cells synchronously, or at least for all those in the atria and separately for all those in the ventricles, how this can be monitored from the surface of the body by electrocardiography. Finally, we'll talk about how electrocardiography can be used to diagnose certain arrhythmias or unusual electrical events that can cause disturbances to contraction of the heart. So let's set the stage for the electrical events that will be happening, part one of our discussion, in cardiac myocytes by describing what the cardiac myocytes are like, what their status is before they reach this, are stimulated by this electrical stimulus from the pacemaker. So, cardiac myocytes have what's called a resting membrane potential, a charge separation across their membrane due to unequal distribution of ions. In cardiac myocytes, the value of this charge separation is minus 90 millivolts, indicating that there's a net negative charge on the inside of the cell, and the outside is a relatively positive charge. So the magnitude of the charge separation is indicated by the number 90 millivolts. In addition, a feature of the myocytes is that the membrane potential at rest, resting membrane potential, or RMP, is stable. From the previous video, you may remember that this is different from the situation in the nodal cells of the SA node, where the resting membrane potential is unstable. In myocytes, the membrane potential remains stable unless stimulation occurs from the pacemaker. And just to refresh everyone's memory about ion gradients, sodium and calcium ions have a higher concentration outside the cell, and when their ion channels open, they flow in. So there's influx of these ions into the cell. Conversely, concentration of potassium ions is higher inside the cell, And when potassium ion channels open, they move out. Okay, this figure is a representation of a cardiac myocyte on the left and its membrane potential of minus 90 millivolts. And that should bring to mind a charge, a net negative charge on the inside of the plasma membrane of these cells, and a net positive charge on the outside of the plasma membrane. If we focus in on the plasma membrane, we'll see the ion channels that are present, and these 3 ion channels are going to be important for the electrical events that are happening in the muscle cells. Cardiac muscle cells are equipped with fast voltage-gated sodium channels, slow voltage-gated calcium channels, and medium or just regular voltage-gated potassium channels. These channels are summarized at the bottom of the slide. For both sodium and calcium channels, when these channels open, cations, sodium and calcium, are going to flow into the cell. And that's going to cause the inside now to accumulate positive charge and become less negatively charged. So this is going to cause the membrane to depolarize. We'll look at a graphical representation of this in another slide. On the other hand, when potassium channels open, potassium will move out of the cell, and that will cause positive charges to leave, and the inside of the membrane will thus become more negative. And that's what happens when repolarization occurs. Okay, we've set the stage for the electrical events that happen in a cardiac myocyte. And so here they are represented graphically, and this is representing change in the membrane potential, how positive or negative the inside of the membrane is on the y-axis, and on the x-axis, what happens versus over time. So these are seconds on the x-axis. There are going to be 3 main events that are happening. One is called depolarization. 2 is what's called the plateau phase, and 3 is a repolarization event. So let's go through these, starting with step 1. When a cardiac myocyte is stimulated by a nodal cell from, let's say, from the SA node, ions will enter, and that'll cause a voltage change to the membrane, which is going to stimulate the first ion channel to open here, the fast voltage-gated sodium channels. When these channels open in the membrane of the myocytes, there will be a rush of sodium ions into the cell. And there will be a very rapid change in the membrane potential from minus 90 now into the positive direction because of all these cations entering the inside of the cell. If we look at a tracing of what's happening here, the opening of the sodium channels will cause a very rapid increase from minus 90 to plus, even up to around plus 30. So that's an indication of how quickly and how rapidly the membrane potential will change due to this opening of the sodium channels. This is called depolarization because the membrane, at least in the beginning, reaches 0 where the membrane is neutral, so it's not polarized anymore. It's depolarized. Now it does surpass 0 to become positive, but the name polarization is still used to describe what happens in this phase. All right, when the membrane reaches this positive value, that's going to trigger, it's a voltage change, which is going to trigger closing of the sodium channels and opening of the other 2 channels. Both the calcium and the potassium channels will open. And when that happens, there will be positive charges entering the cell, calcium, and positive charges leaving the cell, potassium. So there won't be much change in the value of the membrane potential. It will become slightly more negative, but it's mainly stable here for a period of time of about 0.2 to 1/4 of a second. So this is referred to the plateau phase, and during this phase, there's not much change to the charge of the membrane. But there is a gradual decrease in the negative direction, and when this reaches a critical value, this will cause the calcium channels to close, and only the potassium channels will remain open. So in step 3, potassium ions exit through the open of the voltage-gated potassium ion channels, and positive charges are leaving the cell, and because of that, the inside of the membrane becomes more negative, and that's what we can see happening here in phase 3. The inside of the cell membrane becomes more negative, and so it's moving into the more negative direction. So this is a repolarization event. The membrane was initially polarized, negative on the inside, positive on the outside. It depolarized. It went through a plateau phase where there wasn't much change, and then it repolarized back to the resting membrane potential value of minus 90 millivolts. So this electrical profile that we looked at, shown repeated on this figure, in blue is showing the electrical events, the depolarization, plateau, and repolarization, and in red is showing the mechanical event that follows the contraction. And this is building of muscle tension that results from the electrical event triggering it. Now, in cardiac myocytes, because of the plateau phase, the repolarization takes much longer than in skeletal muscle cells. So there's a separation in time of about a quarter of a second, 250 milliseconds, between when the membrane first depolarizes and when it becomes fully repolarized. So because of this separation, there is a period of time during which the membrane cannot be stimulated to contract again. This is what's known as the refractory period. Refractory means resistant. So cardiac myocytes have a relatively long refractory period. So during this green period of time here, between the time it takes for after depolarization for a myocyte to fully repolarize, these cells are resistant to an additional stimulus to cause them to depolarize and contract. If we compare the refractory period of cardiac myocytes, pretty long, to those in skeletal myocytes, what we see here is in skeletal cells, when they depolarize, they immediately repolarize. And so there's a very short period of time, shown in green, during which skeletal muscle cells are refractory or resistant to an additional stimulus causing contraction. Skeletal cells have a very short refractory period, which means they can be stimulated at a very high frequency, and when that happens, they can generate a sustained contraction. Skeletal muscles can sustain a contraction, which is useful for certain situations, like if you have to carry a heavy load, if you're walking home with a heavy load of groceries or something like that. Now, the heart, we don't really want it to have a sustained contraction. The heart functions as a pump, and so a sustained contraction of the heart would not be a pumping action. It would basically be frozen in a contraction state. So what we want the heart to do is to contract and then relax. During the relaxation period, it can refill with blood, and then it contract again to pump the blood back out again. So to summarize, cardiac myocytes have a long refractory period, and skeletal myocytes have a short one. The significance of a long refractory period in cardiac myocytes is that they cannot sustain a contraction, and that's a good thing because we want them to relax. During relaxation, the heart can fill, and they can contract again after this relaxation period to pump blood out. So in cardiac myocytes, there's a requirement for a relaxation period alternating with the contractions. The mandatory relaxation period in cardiac myocytes is also important because it prevents cardiac myocytes from undergoing fatigue, which would not be a good thing for heart muscle cells to do. A fatigue cell cannot contract very effectively, so prevention of fatigue is a secondary important part of the significance of the long refractory period. The electrical events that are happening in the heart happen synchronously for all atrial myocytes and also separately for all ventricular myocytes. Because of the large number of cells that are undergoing synchronous electrical events, these can be detected at the surface of the skin. And so the process of doing this is called electrocardiography. And on this figure, we see a man being set up for this procedure by having electrodes placed on the skin around the area where the location of the heart. In electrocardiography, the electrical events that are occurring are recorded and they are charted versus time. And we'll look at a tracing of one of these in a second. But first of all, just to describe some of the terminology that we'll be using. In the readout, the tracing will show that there's a baseline reading, and this is basically when there are no electrical events happening. And then we'll see that there are deflections from this baseline. And so these are called, basically look like peaks, and these are referred to as waves. The periods of time where the tracing returns back to baseline between waves are called segments. So when we look at a tracing, we'll notice that there will be three main deflections that can be seen per cycle. There's a P wave, and this is indicating the electrical changes that are happening in the atrial cells during depolarization. That's followed by a relatively large complex wave called the QRS complex. And in this time frame, there are two electrical events happening. One is depolarization of the ventricles and simultaneously repolarization of the atrial myocytes. And finally, the third deflection is called the T wave. And during the T wave, the ventricular myocytes are repolarizing. All right, so this shows the typical tracing of an EKG through 2 cycles. And here is the baseline, and here are deflections from the baseline. The P wave, the QRS complex, and the T wave. And then, followed by yet another cycle, PQRS-T. These segments are when the baseline is happening between electrical events. So they're referred to as segments. The P to Q interval or P to Q segment is one. The S to T segment is another. And the segment between a T wave and the following P is a third. All right, so all of these can be examined during a readout of a patient for an electrocardiogram, and they can be used to diagnose potential problems in conduction of electrical signals. In this figure, we're looking at the EKG or electrocardiogram cardiogram tracing alongside what the electrical events are that are happening in the heart. The electrical events are color-coded. Yellow is meant to represent a depolarization event. Red is a repolarization. So here we have the beginning of a cycle in which a depolarization of nodal cells in the SA node is propagated through myocytes in the atria, right and left, through gap junctions, and that causes depolarization of all the atrial myocytes in the P wave. Following the P wave, there's a segment where it returns back to baseline when no electrical events are happening. And then the action potential reaches the AV node, and that will be then transmitted to the ventricles, where depolarization of the ventricles will start. Simultaneously with that, repolarization of the atrial fibers will be happening as well. Following that, there's a segment during which no electrical events are happening between S and T. And then we reach the T wave. During the T wave, the ventricles are repolarizing. And then it returns back to baseline before the start of the next cycle. So this figure is tying the electrical events happening in the atria and the ventricles with the EKG tracing. Okay, the final topic for this video is cardiac arrhythmias. And so I just want to provide a definition for this first, and then go through a few examples. There are many, many examples we could talk about, and it's a very interesting topic. But just a few examples to illustrate will be used in this video. So the definition of an arrhythmia is it's an abnormality in either the rate, the regularity, or sequence of the cardiac cycle. And we'll be talking about two main examples. One is fibrillation, and the other is heart block. Let's start with fibrillation. In fibrillation, there's a loss of the normal synchrony of contraction. And this is due to loss of synchrony of the stimulus, which are the electrical events. Normally, there's synchronous action potentials traveling through all the atrial myocytes and then conducted to all ventricular myocytes. This synchrony an electrical stimulus generates synchrony and contraction of first the atria and then the ventricles. In fibrillation, this synchrony is lost. Now, fibrillation can happen and does happen separately in either the atria or the ventricles. So there are two types of fibrillation: atrial fibrillation, or AFib, and ventricular fibrillation, or VFib. In atrial fibrillation, the loss of synchrony of contraction results in the inability of the contraction of the atria to effectively push blood down into the ventricles. Now, this is not immediately life-threatening because the ventricles fill anyway due to gravity, and the contraction of the atria while completing the process are not critical for the overall process of filling of the ventricles. While not life-threatening, it should be checked by a physician because it can lead to more serious complications later, if not treated. And ventricular fibrillation, loss of synchrony, is a potentially life-threatening event. And the reason for that is if the ventricle fibers are not contracting synchronously, they're not generating a pumping force of blood. And so the heart is not effectively acting as a pump. And so tissues are starting to be deprived of necessary oxygen and nutrients. This is especially critical for cells in the nervous system. So when ventricular fibrillation occurs, the immediate action is needed to restore the rhythm by application of a defibrillator, an external shock, to reset the cycle of stimulation. On the right side of this slide, we see the normal EKG that we just looked at previously, and we can see the P, QRS, and T waves, P, QRS, and T. And that's shown in contrast to what's happening in ventricular fibrillation. You can see there's a random chaotic rhythm where there's no regular repetition of any type of P, QRS, T type waves. It seems to be all over the place and extremely chaotic. That's reflecting the loss of synchrony that's happening electrically in these cells. Because ventricular fibrillation is an emergency and requires immediate attention, time is of the essence in treating someone who's undergoing ventricular fibrillation. And nowadays there are devices that are available in public buildings called AED, automatic external defibrillators, that can be used to immediately treat someone, even if you're not a medical professional. These devices have internal instructions that can instruct and guide a user through the process, and can be used to treat somebody who's undergoing ventricular fibrillation. Another type of cardiac arrhythmia is called heart block. In heart block, there's a difficult problem, some kind of problem with conducting action potentials from their origin in the atria to the ventricles. And usually there's some kind of defect along the pathway that arises due to heart attack or other causes. Some of the symptoms that can be seen due to heart block for more severe cases, are fainting, irregular heartbeats, and palpitations or rapid beating of the hearts. There are different types of heart block, and these can be distinguished and diagnosed through electrocardiography. So I want to take a look at two of them. There's what's called first-degree heart block, and that's what's seen on the bottom of this slide. This is showing what's seen in a normal cardiac rhythm, EKG, in which is a P, QRS, and T wave, and what's seen in first-degree heart block. The main problem with first-degree heart block is that there's a slowing of conduction of action potentials from the atria to the ventricles. Since conduction happens between the P and the QRS complex, what's seen in first-degree heart block is a lengthening of this segment compared to the normal rhythm. And one last slide here showing a different type of heart block called second-degree heart block. In second-degree heart block, there are some action potentials that originate in the atria that are not conducted to the ventricles. So that's what's shown on this electrocardiogram tracing. Here we see there's a P wave, QRS-T, P, QRS-T, and then here we see a P wave in which there's no following QRS or T. So in this particular cycle, the action potential was generated to produce the depolarization of the atria, the P wave, but it was not conducted to the ventricles. That's followed, however, by a number of cycles in which there is normal conduction. So in second-degree heart block, some impulses are not conducted from atria to ventricles. Well, that's just a few examples of cardiac arrhythmias that can be diagnosed by electrocardiography. So I will end this video here, and we'll see you next time.